Hello and welcome. This is Colleen Morley, President of CMSA Chicago. Welcome to an episode of CMSA Chicago Issue Spotlight, our informational video series discussing various issues in case management. Today's video puts the spotlight on case management navigating through pandemic, and it's discussed by Dr. Jose Alejandro, PhD, RN, NEABC, FACHE, FAAN. It's a lot of alphabet soup, Jose. Dr. Alejandro is a director of care management at the University of California, Irvine Health, and the assistant professor at Mount St. Mary's University in Los Angeles. He currently serves as a lieutenant colonel in the U.S. Army Reserve and will complete his adult gerontology acute care nurse practitioner program in June. In addition to serving as the immediate past president 2020 to 2021 for CMSA National, he serves as Sigma Treasurer 2019 to 2023, the second largest nursing organization in the world. He's active with other professional associations, which include serving as board member 2019 to 2021 for the American Academy of Nursing and appointed American Association of Men in Nursing, AAMN. Dr. Alejandro also served as the 15th president 2012 to 2014 for the National Association of Hispanic Nurses. He was awarded the CMSA Case Manager of the Year in 2015 and the AAMN Luther Chrisman Lifetime Achievement Award in 2021. Dr. Alejandro is a Sigma and Virginia Henderson Fellow of Sigma, a Fellow in the American Academy of Nursing, and a Fellow in the American College of Healthcare Executives. Welcome tonight, Jose. Thank you for joining us.
Yes, of course. Thank you for having me, Dr. Morley.
This is a great topic to discuss and very, very timely because, we're in the middle of it. We're hopefully towards the tail end of it. But as an acute care case management director, how does life differ from pre-pandemic to now?
So I think you have to look at it in the sense from, what type of facility you work in. So do you work in the post-acute, which could be a skilled nursing facility and or a long-term acute care hospital. UC Irvine Health is an academic medical center that is the only level 1 trauma center in Orange County, California. So from that perspective, what we have looked like today looks nothing like how we looked before the pandemic. One of the things that we recognized is that our staffing ratios within several of our case management groups, regardless if it was clinical social work, case management, utilization management, is that we needed to downsize the amount of patients that were assigned per case manager, clinical social worker, et cetera, et cetera. We have a four-prong model here. So we have a separation between utilization and care progression. So utilization is done by RN nurses, care progression is done by clinical social work and case managers. And then we have our discharge planning, which is non-clinical personnel that assist in doing the referrals to the post-acute or for community resources. One of the things we identified early on is that we needed to A, extend our hours, and B, really go from a 4.5-day hospital to a 7-day hospital. And so we expanded our services into the evening, expanded our services into the weekend. And then we also looked at our staffing ratios, in which we decreased the amount of patients per each assigned clinician, regardless if you were a clinical social worker or a case manager. That being said, we look completely different in the sense that we do many things very differently. We've had to work more closely with our post-acute providers. We've had to work with our insurance companies for authorizations for the post-acute. And we've also had to work with even DME companies to ensure that we could get oxygen as we needed. One of the things that we faced as an organization is the impact of COVID. Our organization in the first wave maybe saw 70 as the peak. In our second wave, we hit almost 200 COVID patients, and we're probably a 440 bed hospital. So almost 50% of our beds were utilized by COVID patients. Today, we continue to see a decrease in the amount of COVID patients. I think we're sitting at about 76, but a majority of those are ICU level of care patients. And so having to establish that, having to have family care conferences, and how do we look at things differently based on the needs of the individual, needs of the family, and also the needs of the community, and most importantly, How do we navigate our organization during the pandemic when you can't do elective surgeries, and you know that elective surgeries are probably one of the ways that you build upon your programming, and so that has severely impacted the way we do that. We're slowly ramping up again, but knowing that the Super Bowl could be wave number 3, we're a little bit cautious. One of the things we also had to do is we implemented a mobile field hospital in our front parking lot. And so we were able to add 40 additional telemetry beds, which meant I had to staff that. One of the things that I'm very proud of as an organization, as in California, we have staffing ratios, and those were relaxed, and we're one of a few hospitals that did not go outside the staffing ratios for our frontline staff nurses and or for our case managers and clinical social workers.
That's great. The field hospital in your parking lot, we can't do that here in Chicago because snow, but that's an awesome
Right.
idea. So what do you think would be, I mean, long-term lessons learned from this pandemic? What do you think the impact is going to be on clinical case management as a profession?
So I think 2 things. One is we're expected to do more with less, and that could be either from an insurance standpoint for the post-acute resources for our patient population. But one of the things that we struggle with in this part of the world is that we have a very large homeless population. And that could include civilian and veteran homeless individuals. And as from a stats perspective, LA County is the #1 county in the country with the most homeless individuals. And Orange County, which we reside in, is the 2nd largest, and San Diego, being right below us as far as counties, is the 3rd. Having to coordinate not only care progression, but what is the next level of care, and that, not looking at it from an insurance perspective, but looking more from a care appropriation, is probably the thing that we need to look at. So we have to have a highly skilled workforce. From the clinical social workers being able to impact from either short-term therapy and or community resources or navigating family dynamics, to the case manager who has to work with care progression and are we doing the things that we need to do at the right time and moving our patients to the next level of care at the most appropriate time. Research does show that if you miss your window of opportunity, you're going to go through the whole medical cycle again before you have that opportunity with your patient population.
Were you able to take advantage of any of the waivers for telehealth, or were you able to implement any telework for your staff?
So we didn't implement telework for all of our groups. In my role, I oversee 6 areas, and that is case management. We did not implement telehealth. They're still located in the hospital. Clinical social work is still in the hospital if it's inpatient. Utilization management these are the nurses that work with the authorizations. We did implement a remote status for them. Our clinical documentation improvement team made up of registered nurses and foreign medical grads. They were also in remote status, so they worked from home. And then we have the preferred provider network that has our discharge planning or discharge facilitators, and they're on site. They're not necessarily in the hospital, but they are on site. And then the last piece to that is that I oversee GIP hospice from inside the hospital. And so what we did see was an uptake in the number of patients that went into GIP hospice as a result of COVID, and there are multiple comorbidities.
Right. And we had the same lessons here. Just to summarize it up, what do you think are some things that we could do better in the future to be more prepared for this type of an eventuality? What are your key takeaways from it?
I think the key takeaways is that most hospitals have to learn how to operate a 7-day model. I can honestly say in my last 3 hospitals, which are all very large organizations. I was at Parkland Health and Hospital System in Dallas. They're a 800 to 900 bed hospital. At Tampa General Hospital in Tampa, Florida, they're 1,000 bed. And I would say that all 3 hospitals before the pandemic were probably operating on a 4.5 to 5-day hospital week. The pandemic has demonstrated that we have to be a 7-day-a-week hospital. And so what I'm seeing across the country now is that Things that were sacred Monday through Friday are no longer that. We're seeing operating schedules changing. We're seeing additional days in the OR. We're seeing more staffing and support services, including my own. And so as we move forward into establishing what the new world looks like post-COVID, will probably look nothing like what we had before COVID.
I agree with you 100% there. It has really impacted everything from the ground up at the hospitals that we've been working at. Dr. Alejandro, thank you so much for joining us this evening, and good luck out in California. We'll be thinking of you here in snowy Chicago.
Well, I would share with everyone, since it's bright and sunny still out here.
Oh, you're killing me.
Sun.
You're killing me. It's
Yeah.
snowing right now. We got 5 inches over the weekend, and we're getting another 2 or 3 tonight. It's like, it's no fun.
Right. Well,
But
thank you so much for having me.
Appreciate it.